You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we're talking with ONS member Nilesh Kalariya, Research Nurse Practitioner at MD Anderson Cancer Center in Houston, Texas, about managing acute and chronic graft-versus-host disease, which we'll call GVHD from now on, and biomarkers for the condition. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thank you for joining me today, Nilesh.
Thank you for having me, Stephanie.
So to start us off, can you tell us about GVHD? Tell us what it is and how does it present?
So GVHD is a major complication after allogenic stem cell transplant. Sometimes it is also considered as a multi-organ syndrome of tissue inflammation and or fibrosis. And what actually happens when GVHD develops is that after allogenic stem cell transplant, the donor cells or the donor stem cells, which is also known as a graft, would recognize a recipient or the host tissues as foreign and start attacking them, and that's how the tissue destruction happens. And that's how the GVHD would develop after allogenic stem cell transplant. This process involves a lot of biomolecules. Most of them are part of immune system, and there are so many inflammatory cytokines and chemokines. They are, active players in pathophysiology of GVHD. In terms of presentation, so there are primarily three different forms of GVHD: acute GVHD, chronic GVHD, and the third one is overlap between acute and chronic GVHD. So that's where we see manifestations of acute as well as chronic GVHD. Almost 30 to 70% of the allogenic stem cell transplant patients would develop some sort of GVHD, and it would significantly increase mortality and morbidity. And that's why it is very important issues that we have to deal with.
So thank you for explaining that to us. And as a former bone marrow transplant nurse myself, I've seen GVHD and patients who have experienced it and how difficult it can be for patients when they go through this during their post-transplant experience. So can you tell us, are there certain patient populations that would be at higher risk for developing GVHD?
So rather than a specific patient population, I think GVHD is dependent on donor or host, patient characteristic. So there are quite a few risk factors which can increase the patient's risk to have a GVHD. So one of the most important one is human leukocyte antigen disparity, which is also known as HLA in short. So if you are working in stem cell settings, then you must have heard about HLA mismatch or that kind of wordings. So what it means is that before allogenic stem cell transplant happens, donor tissues as well as the host tissues would be tested to check on their HLA, and that would give them information that whether both the tissues are matching with each other or how far they are away from each other. So more the similarities, less chances to get GVHD. If the difference is larger, that means the risk to have a GVHD it's high. Second point is donor and recipient sex disparity, meaning if we have a female donor and a male recipient is there, that means that particular patient has high risk to develop GVHD rather than a male donor giving a tissue to a female donor. The third one is intensity of the transplant conditioning regimen. So that can also increase GVHD risk. And next one is source of the graft, meaning if we collect the stem cells from peripheral blood of the donor, then the chances to have GVHD is higher compared to if we do a cord blood transplant. Elderly patients who are going to receive stem cell transplant have higher risk to get GVHD. So meaning, age is also play an important role, and it's kind of a risk factor to have GVHD. Besides, CMV, cytomegalovirus status of donor as well as host, that is also important risk factor to have GVHD. And that's the reason, we check for CMV infection before we do stem cell transplant. And besides that, besides CMV, Epstein-Barr virus seropositivity is also an important factor to consider because that can also increase the risk for GVHD. So these are some of the risk factors that can increase the risk to have a GVHD after allogenic transplant.
It definitely is a very complicated process for the coordinators that are looking for donors for those patients and looking at all of that, the HLA typing and everything, and then really taking all of those pieces that you just mentioned into consideration for these patients. So, what is the diagnostic process for a patient who you are suspecting is presenting with GVHD?
So, for diagnosis, workup, we rely on clinical evaluation, including lab work and pathology, which involves biopsy sample. For labs as well as the pathology, samples, we also focus on which particular organ is involved, and depending on that, we have to order a particular test. For example, if the liver GVHD is there, then we may have to, get a small biopsy sample from the liver. Or, for example, if chronic GVHD is there in lungs, then we sometimes may have to order a pulmonary function test. So there are a variety of things that we have to do depending on which organ is involved. Traditionally, the way we have practiced is that GVHD is kind of a calendar-driven diagnosis, meaning if the GVHD is developed within 100 days after allogenic transplant, then it would mostly be acute GVHD. If it developed after 100 days, then it would be considered as chronic GVHD. However, this clinical practice has changed now because of the collective efforts by various physicians and scientists. So now we have new conceptual understanding where we incorporate information such as number of organs that are involved, the severity of the condition, functional disability of the patient. So these are the ideas that we incorporate into the diagnostic process. And on top of that, we still rely on the calendar if it is developed within 100 days or after 100 days. So based on that, we diagnose this condition as either acute or chronic, or it could be overlap of both of them.
You mentioned the different types of GVHD, acute and chronic. And then you also mentioned that third, kind of the in between those two. Can you explain what the similarities and differences are between actually, I guess, the three of them?
To talk about similarities and differences, yes, we do have some similarities between acute and chronic GVHD, but at the same time they would also differ in some aspects such as in the underlying pathophysiology, clinical manifestation, and management. So let me tell you first about acute GVHD, which usually manifest as an inflammation which primarily dependent on the role of T cells in the pathophysiology, which would ultimately lead to tissue destruction and apoptosis, which is cell death. So, in a nutshell, this condition is primarily driven by activation of donor T lymphocytes, and it would lead to release of so many inflammatory cytokines. And once that happens, so this would be manifested as a skin rash, which would be skin GVHD. In terms of GI GVHD or gastrointestinal GVHD, the symptoms would be a little bit different, where we would see abdominal cramping with profuse diarrhea, persistent nausea, vomiting. So this would be the symptoms for GI GVHD. While if the liver is involved, then we would see yellow discoloration of the skin and or eyes, kind of a jaundice type presentation. And we would also see a rising bilirubin level in the serum or plasma. So this would be the different kind of manifestation depending on the organ that is involved. Mechanism wise, I think we have understood very well, and that's why we are able to manage acute GVHD very well at this moment. And as I mentioned, skin, GI, and the liver. These are the three organs that are frequently would have acute GVHD. But compared to acute GVHD, chronic GVHDs are a lot different because the pathophysiology would be different in a chronic GVHD, which may involve fibroproliferative changes in the tissues. And compared to acute GVHD, chronic GVHD, there are so many organs that can be affected, including skin, liver, GI, nails, hair, mouth, lungs, eyes, neuromuscular system, connective tissues, any soft tissue organ with mucus in there. So those are all that organs that can be affected by chronic GVHD. Now you can see that there are so many organs are involved, and each and every organ has a different manifestation. So symptoms that you see would be quite different. So that's why chronic GVHD is kind of a big challenge for us. And so far, we are still have not been able to understand pathophysiology very well, and this still remains a challenge for us.
So, Nilesh, with all of the different organs that can be involved and looking at the, whether it's an acute onset or a chronic onset, there must be many different treatment options. So, what are the treatment interventions used to, let's start with acute GVHD?
Traditionally, in terms of treatment, the first line treatment would remain same for acute as well as chronic GVHD, and that would be systemic steroid. Sometimes we do have to use a topical steroid if the skin is involved. So we may not require systemic steroid if the GVHD is milder version, but for most of the time we do rely on systemic steroid. So about 40 to 50% of the patient would not respond to the steroid. And so those patients would be considered as steroid refractory patients. And for them, we have to rely on second or third line of treatment. Now, in terms of acute GVHD, if we have to go on second line of therapy, then we have so many options where we can target T cells, we can target interleukin 2 receptor alpha. We also have some therapies which can target TNF alpha. All of these are kind of a monoclonal antibodies, so it would be kind of a targeted approach. For example, if you want to target T cells, then we can give ATG for interleukin 2 receptor alpha. We have daclizumab, basilizumab, inelimumab. The names are pretty difficult names, but we have different kinds of monoclonal antibodies that can target interleukin 2 receptor alpha. Similarly, we have infliximab, that sort of a monoclonal antibodies that can target TNF alpha. And as you know, that interleukin 2 as well as TNF alpha are the most important cytokines which play important role in inflammation in whether it is acute or chronic GVHD. Besides this one, we also use extracorporeal photophoresis, where it's a kind of a apheresis where we try to kill mononuclear cells, which are kind of a donor cells which can attack host tissues. So by doing this photophoresis, we can try to kill those cells, and that's how we can contain the GVHD progression, or we can decrease the severity of the condition. These are some of the approaches that we use for acute GVHD. And for chronic GVHD, as you know that it is a complex process, and there are so many different target organs involved in chronic GVHD. So the list for second and third line of therapies for chronic GVHD is actually longer than what we do in acute GVHD. Of course, we can do extracorporeal photophoresis as second line, but for chronic GVHD, we have so many more options available, such as tyrosine kinase inhibitor, ibrutinib, that is well-known TKI inhibitor. We can use rituximab, which is CD20 monoclonal antibody. We can use mycophenolate mofetil, which is anti-metabolite. So that is also part of second line therapy. Jakafi, that is another one, which is JAK kinase inhibitor. mTOR inhibitors such as sirolimus, everolimus, those are the mTOR inhibitors that we can use. There are several other multi-kinase inhibitors. Besides, we have methotrexate, which is anti-metabolite. So all of these are part of second line treatment for chronic GVHD. And this list is not what I just said. There are many more therapies that are there which we can use. If the second line of therapy doesn't work, then we have third line of therapy. And usually what they do, once you are exhausted with all the second line therapeutic agents, then you can jump onto the third line, which includes inhibitors for T cell activation. Then we have anti-interleukin 6 receptor antibody, which is known as tocilizumab. We have some alkylating agents such as cyclophosphamide. So yes, we do have several options. And just to let you know, recently the FDA has approved ROCK2 inhibitors, which is known as belumosudil. So this is a new drug that is available for chronic GVHD, but this one should be used if our first and second line doesn't work. So that's how the FDA approval is. But yes, we do have several options in terms of GVHD management.
Now, with those treatment options, are there any specific nursing considerations that our listeners would need to know if they had a patient who was receiving some of those treatments?
Yes, nurses actually play a very, very important role when they are taking care of a GVHD patient. Most of the nursing consideration, or the role for nurses is to understand how a particular therapy is working, and what would be the potential side effects of those therapies, so that they can let the provider know if there is any potential side effect which is about to happen or which is ongoing. For example, if you use systemic steroid, and many times if the severity is high, then we usually put the patient on high dose steroid therapy. So we know that there are so many side effects with systemic use of steroid. I will just give you two examples. One is glucose management, and second is myopathy. So these are the two important side effects, and there are so many others. So if nurse is familiar with that, nurses can play important role in making sure that the patient's glucose level is under tight control. And in terms of myopathy, we just want to make sure that physical therapy is on board, and we can work with the patient to make sure that muscle strength is intact, and patient is moving around, just to maintain quality of life and the functional abilities of the patient. Besides steroid, the second and third line of therapies, as I just mentioned, quite a few of them, and you now know that all of those agents are kind of a targeted therapy, which is targeting particular things, and most of these agents are part of a, we call it immunotherapy. So as you know that immunotherapy has have their own different set of side effects, and nurses should be familiar with all of those side effects, just to make sure that if the patient is on a particular therapy or agent, patient does not experience those side effects, and if that happens, we should intervene appropriately and in a timely manner to prevent severity of those toxicities. Now, rather than going through a long list of side effects, some of the things that nurses should be careful about in general, no matter what kind of disease or what kind of therapy the patient is getting. I think some of the items that we have to be careful with is infection, which is a huge problem in a patient who has a GVHD, because the immune system is compromised, and the patients would be on some sort of immunosuppressive medications. So that's when the patient has a high risk to catch any kind of infection, be it viral, bacterial, or fungal infection. So we just want to make sure that patient is on some sort of prophylactic antiviral, antifungal, or antibacterial medication. CMV, that is another huge. Of course, it is a part of infection, but CMV is a huge issue in this population. So we just want to make sure that we keep checking CMV level on daily basis, or based on your institutional guidelines. Like here at MD Anderson, we check twice a week. So we just keep checking on regular basis to make sure that there is no activation of CMV. And if that's the case, then we can put the patient on some sort of CMV management intervention. Change in blood count, or hematological toxicities, that is again a huge concern among the patient. Anemia, thrombocytopenia, those are the things that we have to be careful with and intervene as it is needed. We just want to make sure that hemoglobin at proper level, patient do not bleed if the platelets drops below a certain level. So those are the things that we as nurses have to be very careful with.
With the amount of time that nurses spend with transplant patients, as you mentioned, they are a key part to being able to understand and help in the management with the GVHD. So thank you for going over those. And oncology nurses are definitely learning more about biomarkers in practice. There are biomarkers that can help providers determine a patient's diagnosis or tailoring treatment. Some examples of that might be HER2 with breast cancer and EGFR with non-small cell lung cancer. But with GVHD, that had not been something that was used, but it looks like there's more research that is starting to grow around prognostic biomarkers and things like that with patients who are at risk for GVHD or who have GVHD. Can you talk about that a little bit?
Yes, sure. And you are right. There is a lot is happening at this moment in terms of research. And you are right that, right now we do not have any biomarkers in clinical use at this moment. But whatever the research that has happened in the past 10 to 15 years have led us to realize that, we do have potential biomarkers, and those one can be an important biomarkers for diagnosis as well as prognosis for both acute as well as chronic GVHD. I think in near future we may have those biomarkers available to use in clinical practice. Now the question is that why it is not available, even though we have been trying for so many years. And that is a good question. The biggest barrier for us is that GVHD is a pretty complex condition. And what we have done so far is our efforts were not collective so far. And that's why we struggle a lot. But in 2004, NIH established a task force. Now they called it NIH Consensus Work Group Task Force. So they established 6 different work groups. Each work group would identify a particular area, and they would work on that one. For example, diagnosis and staging. Second group would work on pathology. Third group would work on biomarkers. Fourth group would work on treatment, and so on. So what they have done is, what these groups have done over the years is that they reviewed all the literature or whatever we have done so far in that particular area, and then they come up with a recommendation that how we move forward from here. So based on that recommendation, last few years we design our studies in such a way that we get answer for the questions that we have, and biomarkers was one of the important question with one of the group. So what they did, they suggested the best thing to move forward is to have a collaboration among the different centers, because if one center is working on that, then we may not have enough sample. So what we are doing right now is multi-center studies where everybody would participate, everybody would enroll their patient in the same studies, so that we can get data from different parts of the world, and all sorts of patient population would be there. So whatever the results that we get can be generalized to general population. So what we have done so far is that in terms of biomarkers, so there are 2 important biomolecules that we could identify them as important biomarkers for GVHD. One is protein, second is microRNA. So in terms of proteins, as you know that we have hundreds and thousands of protein in our blood. So we utilize our serum or plasma to explore biomarkers, and after putting all the efforts in last 10-15 years, we have identified at least 8 proteins, and these 8 proteins can become important diagnostic as well as prognostic biomarkers for acute GVHD. For chronic GVHD, we have identified 9 proteins, which can become diagnostic as well as prognostic for chronic GVHD. So none of these proteins overlap. You see the difference here. So we have a separate set of 8 proteins for acute GVHD. We have a separate set of 9 proteins for chronic GVHD, and that is because the underlying pathophysiology is a little bit different, and all of these proteins that we have identified so far are playing important role in the pathophysiology of that GVHD. So that can become an ideal biomarker. So what we have now is, I would say, about 17 proteins. But these are the only proteins that I'm talking about which have been validated in a small study. What we need to do now is to have a larger study, including multi-centers. And once we have that, in fact, those studies are in progress right now. So I'm hoping that in a couple of years, all of these proteins would be validated, and then we might be able to use them in our clinical settings. The list is not only limited to 17 proteins. They have also identified many other proteins, but it is just a matter of larger studies, big studies with a lot of patients in there, so we can get highly sensitive data which can be utilized in a clinical settings. So that's what we are doing. In terms of microRNAs, there are 4 microRNAs that have been identified: microRNA 423, 199A, and then 93 and 377. So these are the names that has been given to the microRNA. But I think the professor who first discovered this, he even got a patent on this one. And this microRNAs can be diagnostic as well as prognostic tools for acute GVHD. We are still working on to find some microRNAs for chronic GVHD, which I'm hoping that in near future we may have some microRNAs that would be available in clinical use for chronic GVHD as well. So this is what the status of biomarker research, which is ongoing at this moment. And whatever the results that we have, it's pretty encouraging. So I'm hoping that we'll have biomarkers available for us in near future.
That's super exciting for those who are working in transplant and for our patients. That's for sure. Can you talk a little bit about, what these biomarkers are providing to our practitioners and what kind of information they are going to help tailor for treatment and management of GVHD?
Right. So that's very important question. Yeah, of course, we order some biomarker testing. We have the results, but if you don't know what to do with that, then there is no point. So what happens? Just to give you an example, there is one particular protein that we have identified called suppressor of tumorigenicity. In short, it is known as ST2. So this protein can be detected in acute as well as in chronic GVHD patients. Whenever the level of ST2 goes up, that means the patient might be resistant to the treatment that we are going to give for GVHD. What it means is that means the prognosis is not that good for that particular patient. So this is the information that we can get from ST2 results when we order that particular test. Similarly, this is not the only protein, but there are other proteins, just to give you a few names, elafin, which is one of the important protein, we find it in skin. Then we have hepatocyte growth factor, in short known as HGF. Then we have interleukin 2 receptor alpha, interleukin 8, KRT18, REG3 alpha. So these are some of the names. These are the proteins that is, we can easily detect in plasma or serum of acute GVHD. In terms of chronic GVHD, we have different proteins called BAFF, CXCL9, 10, 11, and then interleukin 15, MMP3, OPN. So these are some of the proteins that we have identified as a potential to become important biomarkers for chronic GVHD. So when we ordered the test for these proteins, depending on whether the level is going up or down, we can know whether this can be used as a diagnostic or a prognostic biomarker. So let's say the patient presents with clinical manifestation of chronic GVHD, and we order all that 9 important proteins that we think important for diagnosis. So when we order those tests, out of those 9 proteins, there are 7 proteins that can be used as a diagnostic biomarkers, and their level in the blood will go up. So when their level goes up in the blood, that means that can be used as a diagnosis. But we are still working on all of these proteins to develop a protein panel to come up with a diagnostic panel, if you want to call that way, where we would have a multiple proteins on that panel, and that would give us an idea about diagnosis. Not just the diagnosis, but that would also give us an information about which particular organ is involved there. For example, elafin. So when we order the test, so when the elafin level goes up, that means this would be a skin GVHD, because elafin is a part of skin proteins, and so elafin can be a marker for skin GVHD. Similarly, HGF, which is hepatocyte growth factor, that can be used as a biomarker for liver, and it is also to some certain extent we can also use that for GI GVHD as well. So you can see that how these biomarkers important in giving us information to not just to diagnose a patient, but also to see whether this particular patient is going to have a GVHD in near future, whether the treatment that we are going to give, whether the patient is going to respond to that, and what would be the overall outcome, whether the patients, what are the chances for survival. So all those information that we can get it from these biomarkers, whatever the results that we got so far, that have provided this information. But what we need now is, bigger study, larger studies to validate what we have found so far. And once that is done, we would be able to use these biomarkers in our clinical practice.
Nilesh, this has been such an interesting topic that you and I have been talking about, and just really exciting to see the growth that is happening in the area of GVHD with patients who have had a transplant. And I want to, just thank you for your expertise and the information that you've been able to share with us today. And as we finish up, I just have a few questions I'd like to finish the podcast with, and we're going to go over those in a real, quick fire manner. And the first one that I have for you is, what are some common misconceptions about GVHD?
Yeah, this is a good question. Many patients that I have, interacted in the past, many people would have this misconception that, okay, I got GVHD, I'm going to die. That's not true. GVHD is not bad at always. You might hear that physician saying, when they talk with the patient, milder version of GVHD is good, which, when that happens, that means the donor cells are working, all right, and they are able to kill the target cells. So, it is good that we have cells which are working, and they can kill tumor cells. But once the severity becomes, what we would say, when the GVHD becomes severe, so that's when we start having a problem where the donor tissues goes out of our control, and that's when we have to intervene. And many a times that can lead to poor prognosis for the patient. But yes, milder version of GVHD is good. GVHD is not always bad. To have a mild GVHD is good, and we do have so many options to manage GVHD. Not all the patients who get GVHD will die. Of course, we do have many patients may die because of so many other reasons. So one should know and one should be aware of that.
Great. What's something about GVHD that's not often discussed, but you wish people knew more about?
Well, many people actually don't know what has happened in last few years. Usually, people think that GVHD is very complex and a huge challenge for the providers, but that is not the case anymore. Now we are able to manage GVHD very well. We have been able to identify clinical manifestations early on, and then intervene early on so that we can prevent the severe forms of GVHD, and that would also help us to limit our for example, if we have to use a high dose therapy, but if we know early on, then we may not have to use high dose therapy. Even with low dose steroid, we can still manage the GVHD, which is good for us. Besides that, something new that is coming up or has been ongoing in terms of research is microbiome research. You may have heard about fecal transplant or stool transplant. So that is basically, we get a stool sample from a healthy donor, and then we transplant that fecal sample into GVHD patient just to replace good bacteria or restore good bacteria in their GI tract. And as that there are so many good bacteria, they play important role. They help our immune system, and when that happens, actually that can help to manage GVHD. And research is in progress We have seen, very promising results in terms of fecal transplant. And, that is, again, a new strategy for GVHD patient. And that is working for so many patients.
What additional training or education do oncology nurses need to manage patients with acute or chronic GVHD?
I think, what we are trained so far based on the knowledge that we have at this moment, we have been doing pretty well. But in last few years, what is happening now is several immunotherapeutic agents now being used as a second or third line of therapies for GVHD. And as you know that we have more than 50% of the patients would be steroid refractory. So meaning that, almost 50% of the patients would be requiring second or third line of therapies. And most of those agents would be immunotherapeutic agents. And as you know that immunotherapy brings its own set of toxicities. So, and there are several of them. And in near future, we may have even more therapeutic agents, which is good one way, but at the same time, we as nurses must be aware of the potential side effects with all of those agents. And that really help us to be ready to manage GVHD patient whenever the patient experiences any kind of side effects. And that is something that we have to focus now. Otherwise, in terms of general understanding about GVHD and their symptoms, the kind of different diagnostic or any other workup that we do, we are quite familiar with that. This is something that I think we should focus on to know more about immunotherapeutic agents that we are using for GVHD management.
Great. And lastly, what are some additional resources, either for providers or patients who want to learn more about GVHD?
So, yeah, of course, we have lots of resources out there. Even ONS has published so many books, and, there are so many other online audio and videos are available. But personally, for me, because the research is happening so fast these days, I think something that has worked for me is that we should be relying more on resources such as UpToDate, and we should look for research review articles or meta-analysis articles that has been published in journals. So I think if we rely on those kind of resources, that would give us most up-to-date information rather than relying on a book which would take some time to modify and publish next edition. That would take some time. So we may not be keeping ourselves up to date with what is happening right now, but with up to date, which is being updated from time to time, always we can get the most recent information that is out there. And so those sort of resources really help me. And I would encourage all the oncology nurses who are interested should refer to those kinds of resources.
Thank you. Nilesh, thank you so much for joining me today and for all of the information that you have shared with me and with our listeners. I'm sure that those listeners that we have are really going to be able to take a lot of the information back and share that with others, and just look forward to the exciting advancements in biomarker testing and diagnosing with GVHD. So thank you so much for joining me. Do you have any final comments?
Well, no, I just want to highly encourage all the oncology nurses who are out there to stay hungry for more information. And there is a lot of knowledge out there. We can equip ourselves with all that knowledge that is available. And as they say, knowledge is power. So, let's become powerful.
Thank you so much.
No problem. Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.